Okay, cool. So we're going back to the original program. So I'm going to talk about early treatment of small choroidal melanomas, and we talked a little bit about how do you define a melanoma and what's an indeterminate and what's a melanoma, and I think Aaron will be talking a little bit about that when he gets his slides up. I've got a few financial disclosures, but they're not relevant to this talk. So when we talk about small choroidal melanocytic lesions, as Aaron said earlier, it's hard to define what you call a nevus, an indeterminate lesion, and a melanoma. And most of those ones in those previous studies about most of them don't grow are the ones that don't really have many risk factors. So the majority of them didn't have orange pigment, subretinal fluid, and so they're just basing things on size a little bit. I'm focusing on these lesions, which are very obviously small choroidal melanomas. So they're not indeterminates, they're not nevi, they are melanomas. So these ones with orange pigment, subretinal fluid. This one grew over time. And even on the ultrasound in these small lesions, you can see low reflectivity, and you might just be able to see a little Doppler in the middle there. So clinically, these are malignant small melanomas, and it doesn't make sense to say all small tumours are benign, because at some point, all large tumours started off as small tumours. So these are small choroidal melanomas. Is it worth treating them early or not? The problem with most of these smaller tumours, and these are all, the pictures I've all shown you are biopsy-proven melanomas. They're not indeterminates, they're not nevi. They tend to be at the posterior pole, very close to the fovea, very close to the disc, and so the price to pay is significant loss of vision, really, and is it worth it? And it's only worth treating if you're going to save something, and the only thing really saving here is life, reducing the risk of metastatic mortality. So can we reduce the risk of mortality with early treatment of melanomas? The traditional thinking is no, that metastatic spread or metastatic seeding has happened well before presentation, and so any intervention really doesn't change your metastatic risk. However, that slightly old-fashioned traditional method of thinking is defined from very old studies now. So studies like this in the 70s, when the majority of cases were large tumours, when we enucleated lots of eyes, rather than the very small lesions we're now picking up by the optician at an earlier stage now. So this is a little bit irrelevant now. We talked about circulating tumour cells, but again, these are detectable on presentation in a proportion of patients, but again, they tend to be the larger tumours rather than the smaller tumours. Maybe we have an opportunity with these smaller tumours to treat them early and prevent this happening. And also cell-based studies that have modelled timelines of metastatic spread on exponential cellular growth. And these are cellular studies, and we know that in reality, this kind of exponential growth doesn't happen in actual tumour cells with limited blood supply. So we have to look at things a little bit differently. You start off, obviously you can't do an RCT on these patients. You can't say, well, I'm going to treat half of you and not treat half of you and see how many of you die. So that's never going to happen. So we're going to have to look at slightly more indirect data for this. If you take diabetic patients obviously die more of ischemic heart disease, strokes, all the vasculopathy type things, but they actually die less of other diseases. The reason being is that they're so systemically well screened and they're monitored so often that they actually get picked up with other illnesses a lot sooner than the general population. And the same is true for melanoma. So if you get this population of patients that are picked up on diabetic screening because they have retinopathy photos every year versus the rest of the melanomas that we see, they actually have a better survival curve, theoretically because they're picked up earlier and treated sooner. We do know from multiple studies that the smaller the lesion, the lower the risk of metastatic mortality, and it's been shown in many, many papers, particularly the Shields group, that show that every millimetre increase in tumour size causes an associated increase in metastatic risk. So if you do watch these small melanomas and wait for growth, they will be increasing in size over time, and theoretically there is an increased risk of metastatic spread. And they have shown that if you increase by 1 millimetre, especially in these small tumours when 1 millimetre is actually quite a big proportion, you can increase the risk of 10-year metastatic risk from 6 to 12% increase in metastatic risk. We've looked at a lot of biopsies, and Aaron talked a little bit about how you can't read diagnoses without a biopsy. So we looked at all our small tumours. These are the ones less than 2.5 millimetres as per the COMS definition of a small melanocytic lesion. And of those small lesions that we have treated, over a quarter of them are actually monosomy 3, nearly a third have high genetic risk factors for metastatic disease. The other 3/4 are not, but a quarter of them do have high risk features cytogenetically, and these are small ones like this. And if you look at the mortality of these patients, these are the disomy 3 tumours. These are the monosomy 3 tumours. These are the small tumours that have a very high risk of metastatic potential cytogenetically, but they're small. They have a much lower risk than those bigger tumours that have monosomy 3, almost half, so about 65% mortality risk versus a 35% mortality risk if you treat them at this stage rather than at this stage. So theoretically, you want to be treating these small lesions earlier and treating them when they're at a small level. Gustav Stahlhammer from Stockholm is a big proponent of treating things earlier. His recent paper suggests that every 10-day delay in treatment causes an increase in metastatic risk. I think that's probably a bit dramatic. I don't think any of us can stick to a 10-day rule realistically, but we've also done some modelling on disomy 3, monosomy 3, and different rates of tumour growth. And realistically, over 12 months, if you watch these patients for 12 months, there is an increased risk, but mainly in the monosomy 3 category, by up to 7% increase in metastatic potential. So do you then just treat the monosomy 3s? That means you can't do that clinically. You have to do that with a biopsy. This is one of our biopsies. You can see the hole in the retina there. And you can do that and look at monosomy 3 characteristics and maybe just treat that group of population of patients. These are slides taken from Jens Kilgaard, who's done a lot, though, on mutational burden. And the problem is that, yes, you can treat just the monosomy 3s, but the disomy 3s, you don't know what they're going to do over the next 10, 20 years. You don't know how they're going to behave. And there is an increased mutational burden over time where you get more and more subpopulations with different mutations. And at some point, one of them may mutate to get higher risk characteristics and metastasize. And we've all had these types of patients that have been stable for many, many years. And then all of a sudden, something happens within that tumor that makes them grow and suddenly explode. But, so it does sound like if you treat small tumours early, you do change their risk of metastatic disease, but the price is vision. Like I said, they tend to be posterior tumours. And if you do a plaque, quite a significant proportion, this is early data, about a quarter of our patients get some extraocular movement abnormalities after plaque, and about half of those have symptoms on lateral gaze, maybe not primary gaze, but they do have symptoms. It's quite a significant side effect. You don't, with these small tumours, get the cataract, rubiosis, red eye, pain, but you will get significant changes in vision. So how can you treat these patients early, but try and preserve vision? There's a number of ways to try and do that as much as possible. We talked about just selecting who you're going to treat with diagnostic biopsies. You can shield the retina from radiotherapy. You can move the field of radiotherapy away from the fovea and the optic nerve, or you can just treat the side effects of radiation. So there's a couple of papers on silicone oil shielding at plaque treatment. There's a bit of variation in results, but some of the in vitro studies do show that you get an attenuation of radiation dose to ocular structures if you fill the eye with silicone oil at the time of plaque placement. So that is a potential. I think it's probably more important in those who use iodine plaques because there's a lot more spread and a lot more scatter, whereas with the ruthenium plaques there's a lot less spread and it's a bit more specific and well-defined. So that's probably less relevant in the ruthenium plaque population. The advantage of the ruthenium plaque, because it's so specific, you can eccentrically place the plaque so that you are avoiding some of the visually important structures like the disc and the fovea. So this plaque, for example, the scar is just missing the fovea, and this one as well, just missing the fovea. The autofluorescence sometimes shows you a bit more accurately exactly where the plaque was placed, and you can see how specific that border is, and you can see that even more clearly on the OCT, where the plaque has been placed basically just here, saving the fovea. And this patient kept very good vision, 6/9, but obviously has a visual field defect over in the nasal aspect of their visual field. You can also use notch plaques, and you can also notch if you use proton beams. So this patient that's got this fairly posterior tumour, you can notch the beam so that you get a less dose. So this is 100% dose of the protons, 90, 70, 20, and you can try and minimise the dose to the fovea, minimise the dose to the nerve by creating a difference in beam kind of shape to be able to protect some of those ocular structures as well. And then you have side effects of radiotherapy, mainly radiation retinopathy. The bigger the tumour, the younger the patient, and if they have other vasculopathies, they're more likely to get radiation retinopathy. And it can either be, this is a patient who had optic neuropathy, proliferative retinopathy, ended up with PRP, and you can see that optic atrophy here. really awful blood vessels here. To be honest, they would have ended up with poor vision anyway because the tumour's subfoveal with foveal atrophy, but vision-wise, this patient has not done very well. So how can you treat radiation maculopathy? You can treat them with anti-VEGF injections. Doesn't really matter which anti-VEGF injection, they all seem to work quite well. They don't work in everybody, but they do work in the vast majority of patients. And there's more and more evidence that prophylactic treatment with anti-VEGF injections actually preserves more vision. We may be over-treating if we treat right from the day of radiation to the day of retinopathy, because it takes about 18 months to develop, but certainly prophylactic treatment is having more favourable results. In the NHS, we probably can't afford that. The other option is steroids. It's probably a vasculopathy inflammatory process as radiation retinopathy, and so steroids do work. They often do improve the OCT, but they don't always improve the vision. So sometimes you end up chasing the OCT rather than the vision, so it's worth just thinking about whether it's worth doing in a patient or not. And the last option is to go, okay, radiation causes a lot of damage, try something a bit more conservative like laser. PDT is an option, and it does work, but when it doesn't work, it really doesn't work, and it only works in about 50% of cases. So this patient we treated with PDT, because otherwise, obviously, with radiotherapy, they're going to get maculopathy and optic neuropathy, but it didn't respond, so they ended up with protons anyway. And the last thing is Belsar, which is in phase 3 clinical trials, which is a bit like PDT, but it's a viral-like particle injection that's light activated in the suprachoroidal space, the laser that is a bit like PDT that activates that area in the area of the tumour, and it's shown very good tumour control as well as very good visual retention, and so that may be something that we treat these smaller tumours with in the future. So in conclusion, you have to define the difference between small melanocytic lesions that are not melanomas or may not be melanomas versus the ones that really are clearly melanomas. And I think if you are treating the small melanomas, treating them early does make a difference to metastatic risk, particularly if they're monosomy 3, which actually you can only tell if you do a biopsy. Newer strategies like moving the radiation field or oil shielding might help with vision, but realistically, if the tumour is next to the disc or is under the fovea, irreversible visual loss is pretty much inevitable. Thank you very much.